Ladies and gentlemen, it's a pleasure to be here in the Mediterranean Society meeting. I'll go very quickly over these slides. This is a slide showing how did it start in Bari, Italy by Antonio Quarenta. I was honored to be one of the founders representing Alexandria, and Dr. Hassan Sulaiman was presenting Cairo. We had a third meeting for the Mediterranean Society in Alexandria in 1994. What is the current status of intratympanic drug therapy? We have so many million people who are suffering from sensory neural hearing loss, and there is no single FDA-approved drug intratympanic for prevention or treatment of hearing loss. Hearing aids and cochlear implants are the only approved FDA currently. Who is doing intratympanic drug therapy? Almost everybody. ENT doctors, audiologists, otologists, and two drugs are in focus, dexamethasone and gentamicin. How can we approach the inner ear? There are many, many gateways, but the round window is the main gateway. So you have to really study the anatomy and pathology. And this is an excellent reference. I want you to go back. And we published this in 81 together with Terry Stewart. It's a beautiful demonstration how every round window is different from the other. And this we call body prints. The entrance to the round window is so variable. As well, there are anatomical variations in the presence of a partial or a complete false membrane, which is outside the true round window membrane. So we'll talk of three stages of intratympanic drug therapy. The stage one started in 1956 by Harold Chuknecht in Boston. He was injecting streptomycin, and he used to inject 6 consecutive injections. He had 100% control of vertigo, but also 100% of profound sensory neural hearing loss. Then Lang introduced the transtympanic aminoglycoside, which is gentamicin as we know it now. There is something happened here. ممكن حد okay. Silverstein in Florida introduced the dexamethasone intratympanically, 1996. How we do the intratympanic drug therapy? Very easy, office setup, local anesthesia, injection in the anterosuperior quadrants. We use usually dexamethasone or gentamicin. If we want to reach the basal coil, we inject 1 injection. If we want to reach the apical coils, we inject multiple injections. What are the drawbacks of the intratympanic injections? The success rate is not very high because almost 90% of what you inject goes down the eustachian tube at the time of the injection. Only 10% would reach the hypotympanum and get into the round window. And as we said before, there is sometimes a false membrane that prevents even the drug to reach the true membrane. How? So we now moved to the second stage from 2020, which is the transtympanic rather than intratympanic. And this we can, it has to be in the OR. We do a posterior myringotomy. We do it either endoscopic or microscopic. We remove the false membrane. If it is there, then we put some gel foam in the round window in contact with the membrane. And we put a tube, grommet tube, at the end so that we can use it for further injections if we need to. So in this stage, the indications have widened, both for vertigo and sensory neural hearing loss. These are some of the indications of intratympanic therapy that we are doing now. These are some indications for the sensory neural hearing loss. And there are more drugs which are available for injections, like what we use in tinnitus, like monoclonal antibodies in autoimmune, sensory neural, and so on. Now we come to the third stage, and this is a very important stage because what I'm going to tell you now is what represents the future of otology in the next 20 years. So what's coming up, there are new drugs which are on the market. There are at least 43 pharmaceutical companies working on new drugs that helps the cochlea. Then the role of regenerative medicine, stem cells, gene vectors, growth factors, nanoparticles, biologics, exosomes. You have to get used to these terms because this is what we are going to use for regaining hearing for the deaf people. So in the third stage, as I said, when we use stem cells and we use other things, we are confronted with a true round membrane. This is the transmission electron microscopy and the scanning electron microscopy of the round window membrane. It shows you a membrane which is made of 3 layers. This won't allow the cells to get across. So what we're talking about is intracochlear drug therapy rather than intratympanic. And this will necessitate from you a full exposure of the round window membrane. So what you need to do is exploratory tympanotomy, reflection of the eardrum, like what we do in stapedectomies, or exploration of conductive hearing loss. And then we expose what you see here, the round window niche and the true round window membrane. Then with very fine needles, we go through the true membrane, inject our stem cells or exosomes or whatever inside the cochlea, and then heal the perforation in the round window membrane using hydrogels. So this is the what we're going to come into in the next few years, stem cell-based therapies, microimplants that we can put in the round window niche, either slow release or fast release of drugs, micropumps put in the round window, and new gene therapy. I'm sure that you read about the breakthroughs of treating some children with gene therapy. So 2 years ago, we were aware of this, and we had a round table on otology and regenerative medicine in one of our meetings on otology on the Nile. We are lucky in Alex because we have a center. This is written in Arabic, so maybe you cannot see the details, but this is the Center of Regenerative Medicine in Alexandria. We have a clinical trial center. We have a gene therapy center. And I thank you for your listening. And I call on Mokhtar Bassiouny, who is the first panelist in this round table. Please, Dr. Mokhtar.
Nice introduction, Dr. Aziz. My talk is about intratympanic therapy. What is intratympanic therapy? It means targeted drug delivery to the inner ear via the round window with intratympanic injection of various drugs through the tympanic membrane. The round window is the main gateway to the inner ear. The blood labyrinth barrier is a major physiological divider separating the inner ear from systemic circulation. In other words, at tolerable systemic dose levels, therapeutic concentration may be difficult to achieve inside the inner ear. I first start talking about intratympanic gentamicin. The rationale: gentamicin is readily absorbed through the round window membrane to the inner ear. And it shows a selective and earlier toxic effect on the sensory vestibular epithelium much earlier than the organ of Corti. It is indicated in Meniere's disease and benign paroxysmal positional vertigo when repositioning techniques failed. And for Meniere disease, it should fulfill certain conditions. It should be unilateral Meniere with unilateral sensorineural hearing loss. MRI should be free. The middle ear should be free. And of course, that should be after failed medical treatment for Meniere's. The rationale: gentamicin is readily absorbed through the round window membrane to the inner ear. I'm going back, I'm sorry. Advantages. You treat one side without affecting the other side. It is very low cost compared to the alternative destructive treatments. For example, vestibular neurectomy or labyrinthectomy. And it is very low risk compared to the above procedures. It's minimally invasive, no need for general anesthesia. Very high success rate regarding vertigo control with minimal or no hearing deterioration. We have two methods of administration, either low dose intratympanic gentamicin or high dose. We start with the low dose intratympanic gentamicin that I recommend. We give one injection of 4% gentamicin, and this may be repeated after 1 month. Mayo Clinic results: 84% complete control of vertigo and no change of hearing. The high dose intratympanic injections, we give 3 to 6 injections of 4% gentamicin repeated weekly, and we stop when signs of cochlear ototoxicity ensure or occur, that's tinnitus and hearing loss. Higher incidence of hearing loss, gentamicin has a delayed ototoxic effect extending over weeks and months, and it is difficult to know if you have given enough too much or too low over a week. How I do it? I do it in my clinic under the microscope. I position the patient supine, head turned 45 degrees to the opposite side, with a pillow under the head that is anti-Trendelenburg position. And in that position, any fluid in the middle ear will go inferior and posterior of the tympanic cavity and should cover the round window. This is the round window, and we would like to cover it with the fluid, and that's what happens if you position the patient in that position, and the round window is your target. Site of injection is anterior. We inject anterior part of the tympanic membrane. And as you inject, under the microscope, you can see the level of the gentamicin going up. And you stop as it reaches the umbo. By that position, you are 100% sure that the fluid is covering the round window. But if you inject posteriorly, and as you inject, and as the gentamicin reaches the puncture site, it will start to ooze out and may not reach the round or cover the round window. Anesthesia. I used no anesthesia, no general, no local. And I'm telling you, it is very tolerable. It is very, when you use a very thin or fine needle, it is very tolerable. I use a dental needle and a dental syringe. The needle should be the extra long one so that you can reach the tympanic membrane. Usually have got a gauge of 27. This is very thin, very fine. The syringe, I use the aspirating dental syringe. You know, there are two types of dental syringe. Non-aspirating one and aspirating one. The aspirating one has got some sort of a harpoon or say a corkscrew, something that will lodge into the cork plunger of the syringe so that you can aspirate. What to do? I use a anesthesia carpool, dental anesthesia carpool, and I lodge it in my syringe. I then place my needle, I get the cover out, and I get rid of all the anesthesia inside the carpool. I don't want any anesthesia inside. And then I will aspirate my gentamicin. After I aspirate my gentamicin, I will get rid of any air bubble inside the syringe or the carpool. Okay. After I inject, I leave the patient in that position for 30 minutes. 30 minutes is all I need for the round window to be covered by the gentamicin, and during that time, it will just go to the inner ear. I don't need more. This is a low dose intratympanic gentamicin. I repeat, I do it once, and I may repeat it after 1 month if symptoms maintained in the last week of the month. If vertigo occurs in the first 3 weeks, it is not important because the gentamicin is taken into the dark cells of the inner ear, and it will just release slowly. So we think that the effect will occur in 1 month. So if vertigo is still there in the last week of the month, I will inject again. So we will repeat it if symptoms is maintained in the last week of the month, and I can repeat that up to 4 times with at least 1 month apart. If in 4 months it is not enough, we know that there is something wrong, it is failed. They maybe should some fibrous tissue or false membrane over the round window, and it won't work. Now, I disagree with Dr. Belal. I think that the success is excellent. The overall success with substantial remission of vertigo is 92%. The absolute success rate, complete remission of vertigo is 74%. The overall reduction in healing is minimal, 1.5 dBs, which is neither clinically.
Doctor, your time is up.
تهيألي أنا أخذت أقل من دقيقة من 10 دقائق دكتور عزيز. كان أكمل شوية؟ Neither clinical or statistically significant. Word recognition is worsened by 2%. Now, intratympanic steroids quickly. Indications in sudden hearing loss, autoimmune inner ear disease, sometimes in ear disease and in tinnitus. The rationale, systemic corticosteroids is relatively contraindicated in patients with diabetes, peptic ulcers, TB, hypertension, and some other systemic disorders. The intratympanic route results in significantly higher inner ear levels or concentrations of corticosteroids as compared when you give it by the systemic route, maybe even 300 times in case of hydrocortisone and 700 times in case of methylprednisolone. Intratympanic steroids significantly improve the prognosis in sensorineural hearing loss that has failed intravenous or oral steroid therapy. We give it either intratympanic or self-administered. The intratympanic type is the same as gentamicin, as just described. And we repeated twice a week. 2 to 3 times weekly for 2 weeks or something. And topical steroids through a ventilation tube. We insert a grommet tube in the posterior inferior quadrant just against the round window. And then the patient is instructed to lie on his side or her side, and 5 to 6 drops into the affected ear and should fill the medialmost part of the external canal and cover the grommet. Tonby maneuver is performed, that's swallowing while occluding the nostril, and when you do that, all the drug in the external ear is sucked into the middle ear, and this may be repeated every other day. The Tilverstein microwick, which is some sort of a sponge tube put through the grommet to the round window, it doesn't seem very different from simple use of tympanostomy tube, and I think that the additional effort and cost needed to place the special tympanostomy tube and wick, as well as its subsequent removal, are not warranted. Complications: permanent perforation and otitis media. Thank you very much. May I call Professor Alaa for next presentation?
For Meniere's disease. After failure of conservative and dietary treatment of Meniere's disease for 6 months, we can use intratympanic gentamicin for the intractable vertigo, but we have to take care because we can control vertigo but deteriorate hearing because there is some sensorineural hearing loss. Now, no consensus has been reached so far on the overall dosing methods, timing of delivery, treatment duration, clinical endpoint of therapy, or even concentration of gentamicin. A mechanism of action until now we don't know. The cause is unknown, and the action may be due to the disruption of the calcium-dependent cytokine of the cell membrane, usually start with type 1, then type 2. Also, there is a theory that this reduce or inhibit production of the endolymph, and this will restore balance between the perilymphatic and the endolymphatic pressure. The best indication of intratympanic gentamicin is, of course, for the non-serviceable hear or profound sensorineural hearing loss, because you don't have anything to lose. The indication for other ears after medical and dietary treatment for 6 months. Contraindications, usually allergy or hypersensitivity to the aminoglycoside. There are many protocols, maybe more than 50 protocols in the literature, and I summarize the main 3 protocols. The first one is high dose protocol, called the nuclear option because this destroys the ear completely in a few days. 40 milligram per milli every week for injections. The other protocol is low dose protocol, 20 milligram per milli every month, up to 6 injections. And the very low dose protocol, this 10 milligram per milli every month, up to 6 injections. As high dose nuclear options, this 40 milligram every week, as I said, for 4 injections. Usually, we don't reach 4 injections because this very high dose may be the control or just 2 injections. Sensory hearing loss here from in the literature from 19 to 58 of patients have sensory neural hearing loss. This is very high. And the vertigo control is 100%, but we destroyed everything. The ear destroyed already, and this is suitable for non-serviceable ear. A low dose protocol, 20 milligram every month, up to 6 injections. Was sensory neural hearing loss here in the literature from 0 to 12.5 of the patients. Vertigo control here from 95% to 100%. And in my opinion, this is the protocol of choice. The last protocol is very low protocol. This is 10 milligram per milli every month, up to 6 injections. Sensory hearing loss here from 0 to 5%. Vertigo control from 85 to 90%. And this is suitable for elderly patients above 60. Why? Because the patients, if we give the low dose or the high dose, even if you control vertigo, the patient usually complains of chronic unsteadiness or dizziness. Now, where we do the procedure, this is outpatient clinic, and my anesthesia, no injection at all, just spray xylocaine for the external auditory canal for 15 minutes. Delivery methods, Professor Mokhtar make some demonstration, maybe direct, maybe microcatheter, maybe grommet, maybe micro-X, but for me, usually I use the endoscope and I make anterior, superior, secondary perforation, and then anterior-inferior injection of 5 to 0.5 to 1 milli anterior-inferior, and the patient up supine and the ear up and no swallowing for 30 minutes. I have a video about 30 seconds. I will show you after the presentation. What the question is, when I stop injection, I give the patient still vertigo, I give the patient. When I stop, first, when there is clinical control of vertigo, and this is the most important. Or you reach 6 injection without any improvement, you have to stop. Also, any appearance of spontaneous nystagmus, you have to stop. And if you discover high frequency hearing loss. Now, injecting of gentamicin with other agents, some tried to mix with fibrin glue to be more viscous, not escape easily from the Eustachian tube, and the incidence of hearing deterioration is high. Steroids mixed with gentamicin in some cases, usually in the only hearing ear, but the problem is the improvement will be temporary and usually complicated by tympanic membrane perforation. What about the timing of gentamicin? We have 2 protocols, rapid protocol and slow protocol. Please, no need for rapid protocol at all, because there is delayed effect of the gentamicin and may make complications. The slow protocol from 1 month to 2 months this the best idea. Some people give 40 milligram even for every 2 days. Take care, no need for the rapid, and please don't do this rapid protocol. Self-administering, some use a dromit tube and put 5 to 6 drops, posterior inferior, and 3 times daily. The concentration of gentamicin is 3 milligram per milli, and the concentration of the beta-methadone is 1 milligram per milli. But the problem here, 50% experienced worsening of sensory nerve hearing loss, and 40% usually complain from permanent tympanic membrane perforation. How we evaluate the outcome of intratympanic gentamicin? First, clinical control of vertigo. This is the most important. The patient say, I am okay. For complication, we have to do Burton audiograms for check the sensory nerve hearing loss, or we usually make measurement using the vestibular function. VOR gain usually significantly reduced in the affected site. Now, why might intratympanic gentamicin fail? We do everything okay, but no response. Why? This may be wrong diagnosis, not Meniere's disease. This may be migraine. Second, drug delivery failure. Many drawbacks. If the patient swallow too much, there is escape from the ostichian tube. Sometimes most of the injectable material thrown out and so on. So take care. We have to make a good drug delivery good. Round into adhesions. And okay, I will make conclusion only. Okay. With no time here for the conference office, you have to give me time to adjust. I usually like to be perfect 10 minutes, but I don't have where. Okay, this is the last slide. I will, complication, Dr. Mokhtar make it very nice. Sensory hearing loss, sometimes local hemorrhage, allergy, tympanic membrane perforation. Conclusion, the intratympanic injection of gentamicin is most effective non-surgical treatment to eradicate vertigo in intractable Meniere disease. A low-dose protocol is recommended with minimal sensory hearing loss. This is 20 milligram per milli every month by direct injection. This protocol minimizes operation as the laparoscopy and the vestibular neurectomy. Comparison with surgery, vertigo control comparable, overall cost reduced, and the complications are limited. Thank you.
Hello, thank you very much for attending this meeting. I would like to say thank you to the president of this MSOA meeting, Professor Badr, who's always such a kind and generous guest, and I also like this city very much. So we started to be more active in Sorrento, MSOA. I see here some new faces, but the idea as it was presented started years ago, but I think in Sorrento this new generation took a little bit over. So the Italian, the Turkey, the Israeli, and the French, Slovenian, Turkey, Italian again became more active. So this meeting should be more colorful and vibrant. You may not know, but the previous one was in Ljubljana, Slovenia. Unfortunately, Professor Badr was sick, so I couldn't give him the flag. So I took the flag for 2 more years. I got it 2018 in Jerusalem. So I held it to 2022 in Ljubljana, and in Belgrade next year, I was able to give it to Professor Badr Mostafa. So he have it here. My presentation will be a little bit different. So no gentamicin, no dexamethasone, but something new, the plasma rich with thrombocytes and vesicles, which can be also introduced into tympanic cavity and increase the living force of the eardrum and also possibly inner ear. So this presentation is in collaboration. 2 PhD have been done. The third one is going on. And the whole lab support, which is improving the production of this plasma, let's say rich plasma. So in plasma, if you extract, it's full of these vesicles, which has a lot of, how shall I say, stimulating or growth factors, vivant particles, which are used in the plastic surgery, orthopedic surgery, in all kind of regeneration medicine. So as a therapeutic fluid, this was one of our article published 2003. And these particles, these extracellular particles are full of these very, very useful and positive substances. More than 24 of these substances are in each vesicle. So if you get high concentration of this vesicle, you can really increase the well-being of any organ. So we started to use it in the chronic cavity, which are not dry, which are causing problem. So the first use was how to reduce this mucosa growth and these discharge ears. Sorry, this is our protocol. And here you can see how this area causing problems were reduced tremendously in these open ear cavities, which became from always draining ear into almost no draining ear. This was 2-stage protocol. So we take the blood, it's homolog transplant, so you don't need all these precautions. Take a blood, do 2 times centrifugation, and then you extract this plasma, which is rich with vesicles and extracellular, thank you, extracellular particles. So you can see here how the area of this wet and granulomatous tissue was increased much more in the ears where the plasma. So this is a control group. It's not okay. So you can see this is the plasma used. So how this area is reduced and how also here the satisfaction of the patient, it's much better in the plasma group than in the control group. So we published this one, the usefulness of this plasma with these platelets in the chronic postoperative temporal bone cavities. And then we go on and we extend it also to the use of it into the other fields of otology, like anterior skull base, facial nerve. And then we went to use it to, in the tympanoplasties, where we expect bad results. And you can see here, it's not like that all the tympanoplasties are good. You see if the size of perforation is bigger than 50%, then successful rate is only 64.7. So we have a double-blind control study. 38 patients were operated with this plasma and 38 patients without. And we estimate the size of perforation with special techniques, which measure the size of perforation compared with the whole tympanic membrane size. And you can see here we have quite similar groups. And in control group, only tympanoplasty with the spongostan with ciprofloxacin, and here the spongostan with the plasma and also with the gel produced out of this plasma. So you can see here in the control group, after surgery, the PTR, so the hearing was better in the plasma group than in the control group. So not only the closure of the perforation, but also the hearing. So you can see successful rate was also higher in the PVRP group, which is, as you remember from the previous paper, it was 64.7 and we reached 88.9. And also the probability, which could be calculated from our results, you can see here that in the group with the plasma included, it's much, much, much higher in bigger perforation than in the control group. So if you have perforation size up to 70%, the successful rate will be very much lower than if you use the plasma in these cases. So that is how it was made, plasma in the spongostan and the gel out of it. So you can see here in this perforation how it was sealed later on. And then, of course, we use it in the facial anastomosis end-to-end, but we can't do any like double blind or control group out of it. So we can just say we had a good success when we use it on the facial nerve. And then we started to use it in another intratympanic use to protect the aorta tympani when do stapedotomy. And so we do before the the taste tests and the 2-point discrimination test, because aorta tympani, it's not only for the gustatory estimation, but also for 2-point discrimination. And then we stimulate the aorta tympani when we see it at the stapes surgery. So this is the first time we see it. We stimulate it with the electricity and ask the patient when they can feel electricity or something like a taste sensation. So we, with another group, who is shortening the protocol only to one circulation, not two, speeding up the plasma. We make it very fast. So you can see here aorta at the end of the surgery, and we measure the electricity again. And then we made this autolog gel out of patient's plasma in one spine. And we put the plasma, this gel out of patient's plasma on the aorta tympani. And we later on, after 1 month and half a year, remeasure again the taste and 2-point discrimination. So the results are not there yet, but as it seems, in the patients where the plasma was put on the aorta tympani, the post-op results are better. So thank you very much, you, for your attention, and Professor Badr, Mostafa, for having us here. Thank you.
We have a little time for questions. Anybody would like to ask a question? نعم. انت لسه، طب ما طلعتلناش ليه؟ احنا كنا مستنيين لو طلعت. ناس يا عم انت كنت جيت. طيب we have a fourth
Assalamu alaikum. Good morning, my professors, my colleagues. First, I would like to thank my professors in the organizing committee, especially Dr. Mostafa, for inviting me to this mega event. To avoid repeating previous lectures, I'll jump through my presentation to some important points. Sorry for the interruption. Insufficiency neural loss, which is a common condition in our clinics, we can diagnose it from 30 dB or more sensory neural loss at least in 3 consecutive frequencies. It is mostly unilateral, but in 10 to 20% of cases, it may be bilateral. Causes of finger loss is different, and many causes is through conductive or sensory neural. So when you can search on causes of sensory finger loss, we can't find a definite cause. You can find definite only cause. There is multi-theories. This leads to there is no definite treatment. If there is no definite cause, there is no definite treatment. Okay. Multi-series of viral vascular labyrinthitis or toxic drugs. So treatment of sensory hearing loss may vary from systemic steroids, local steroids, antiviral, and other neurotonics, vasodilator, hyperbaric oxygen, which has many researches on it. Why you can't choose steroids? Because it has anti-inflammatory action, increased cochlear vascularity, reduced degeneration of striae vascularis due to its antioxidant effect. And we can obtain this effect even through systemic or local use. Systemic or local use, but also the systemic use have many side effects than the systemic, than the local. So we refer the intratympanic injection of steroid because it focuses the application. Round the window acts as semi-permeable membrane, less systemic side effect, uses smaller quantity of the drug, about half a millimeter in the middle ear. So it's about 4 milligram dexamethasone in spite of 60 milligram of prednisolone systemic. We can choose many steroids, either methylprednisolone, dexamethasone, betamethasone, hydrocortisone. Hydrocortisone is the most irritant, so it's not used today. Causes fibrosis middle ear. Betamethasone has the longest duration, and the dexamethasone is the highest permeability through round window. Indications: the most common indication is idiopathic sensory hearing loss, vertigo, tinnitus, and the middle ear effusion. And this debates, item of debates, why you can use intratympanic injection in otitis media effusion, but many researchers discussed it and has a very fruitful outcome in the through injection in the anterior-inferior quadrant of tympanic membrane. Okay, it's matter of debate. Mode of administration. What's the factors affecting the outcome? That we discussed, this is a patient. Patient ask always the doctor if I'll preserve hearing, if I'll gain my hearing again or no. We have many factors. In patient less than 40 years is better outcome. Time of decorum, mid-frequency loss has the best outcome. The degree finger loss, the profound loss has the least outcome. Presence of vertigo, duration. If the doctor have him a blood clot in the round window in first injection, so the variability of the round window will decrease. So we can do the injection only just penetrating the tympanic membrane, not reaching the voluntary, because any trauma to the ear will keep breathing, bleeding, blood clot will decrease the permeability of round the window, so will decrease the efficacy of the next injection. The spontaneous resolution of sudden sensory hearing loss about 25% of patients. But if we can take the patient or give the patient the full chance with steroids, it will be 75%. So we gain 50% of patients will. In this panel round table, we must find answers for these questions. First questions, other indications, just otitis media effusion, which has debates in Egypt, but have many researches, guidelines, or in papers, many papers and researches in Google Scholar. I have about 60 papers about injection and otitis media effusion. Other drugs, there are just lidocaine, gentamicin, and tinnitus. Tinnitus, not only gentamicin, but we can use lidocaine and the steroids. But steroids, they have a shorter duration. Lidocaine have longer duration for coverage of the tinnitus, but with more vertigo. Intervals of injection, 2 or 3 days, or 1 week, or every month. Site of injection is different from posterior in sudden sensory neural, anterior-inferior infusion, anterior-superior. If a quadrant is different or no. Difficult situation, such as tympanic sclerotic patches, chronic ear. Techniques, I only use just Dr. Mokhtar, the syringe of dental syringe, We can notice the fluid coming. Okay. Posterior inferior, and the fluid were rising through the middle ear cavity to cover the canal.
تمنعش حاجه يا خالد. خالد
Okay.
Yeah.
صعب بقى.
This patient knowing from first snip. The important point that we never touch the promontory. We never touch the promontory.
هنا
اوعى تطلع عليك. Tympanosclerotic patch in some patients. We can through tympanosclerotic patch. Some examples in tympanometry. I don't like to go through effusion, but the message now is is intratympanic injection is perfectly described all over the papers. I don't have any questions to be answered or no. I think is a vague condition about intratympanic injection. I think these questions we must search for its answers through the type, the location, the outcome. Complications, I'll never repeat it. So thanks for your kind care.
Sure. Thank you.